Good morning, everybody. I am Professor Anand, Head of the Department of General Medicine from Sree Balaji Medical College. Today, the topic which I am going to discuss is about diabetes mellitus. The specific learning objectives here is definition, classification, and pathophysiology of diabetes mellitus. Harrison defines diabetes mellitus as a group of common metabolic disorders that share the phenotype of hyperglycemia. Depending on the etiology of the diabetes, factors contributing to the hyperglycemia include reduced insulin secretion, decreased glucose utilization, and increased glucose production. The worldwide prevalence of diabetes mellitus has increased dramatically from around 30 million cases in the 1980s to around 463 million in 2019. Now the classification of diabetes. We all know there are few types of diabetes right from many years, like type 1 diabetes, type 2 diabetes, and gestational diabetes. Type 1 diabetes, which is nothing but beta cell destruction, usually leading to absolute insulin deficiency. There are two subtypes in this. One is immune mediated, another is idiopathic. And type 2 diabetes, which we all commonly know, is predominantly due to insulin resistance. The other types of diabetes like monogenic diabetes syndrome, disease of exocrine pancreas, drug-induced or chemical-induced diabetes, and the fourth one is our gestational diabetes. Out of this classification, the recent one is the monogenic diabetes syndrome. Now, we have seen the different types of diabetes. The type 1 diabetes mellitus, which we all know, accounts for 5 to 10% of all diabetic cases. As I said earlier, it is characterized by autoimmune destruction of the pancreatic beta cells. The most common, which we all know or familiar, is the type 2 diabetes mellitus, which accounts for 90 to 95% of the all diabetic cases. It is characterized by insulin resistance and insulin deficiency and constitutes a major chunk of the disease bulk. Now, another type of diabetes is the secondary diabetes mellitus, which is constitute a small percentage with certain specific conditions and pathologies or disorders like drug-induced. Now, the fourth one, which we all know, is the gestational diabetes, which constitutes around 1 to 14% of all pregnancies which we see. The onset, it usually onsets around the second or third trimester. Now we see the pathophysiology. So there is a genetic predisposition as well as environmental factors that can produce obesity. This obesity will cause insulin resistance at the level of the muscles. So what happens is there is a decreased glucose uptake and hyperglycemia ensures. And there is a deranged insulin release also. So there is an increased hepatic glucose output that also contributes to hyperglycemia. In a nutshell, all these factors will produce type 2 diabetes. In type 1 diabetes, which we have already discussed about genetics and autoimmune involvement, there is some predisposition for infections also. There is a potential association between certain viruses and the development of autoimmunity that leads to type 1 diabetes, like enteroviruses, Coxsackie B virus, rotavirus, cytomegalovirus. And autoantibodies, there is an association between autoantibodies against beta cell antigens and the development of type 1 diabetes. Beta cells are responsible for producing insulin. The autoantibodies destroy the beta cells. As I earlier said, there is a genetic predisposition which may link to type 1 diabetes. The potential association between the presence of HLA-DR3 and HLA-DR4 genotypes and the development of type 1 diabetes. Now the monogenic diabetes. So there are multiple subdivisions in this monogenic diabetes, which we will see. These are usually non-obese patients and heterogeneous clinical phenotype. They do not need insulin initially, later they become insulin requiring, especially certain subtypes like H1F1 alpha and H1F4 alpha defects, which is called MODY1 and MODY3. Isolated mild fasting hyperglycemia, that is defects in glucokinase, occurs in MODY2. There is no treatment required. Diabetes with renal cyst, renal agenesis, that is called H1F1 beta or MODY5. And many cases of neonatal diabetes onset in the first year of life, and the syndromic diabetes like Woolcott-Rallison syndrome and Did-Moat syndrome also monogenic in origin. So the difference between monogenic diabetes and early onset of type 2 diabetes. Monogenic is non-obese, early onset is obese or overweight. In monogenic, acanthosis nigricans are uncommon, whereas it is common in early onset. 3-generation transmission with only one parent affected occurs in monogenic diabetes. Early onset will have both the parents could be affected. Monogenic diabetes have only insulin secretory defect, whereas in early onset there is defect in insulin secretion and resistance. And monogenic diabetes seen in all populations, where early diabetes, onset diabetes is usually seen in population with high prevalence of diabetes. And monogenic responds well to sulfonylureas, whereas early onset diabetes responds well to metformin. Now we'll see the difference between monogenic diabetes and type 1 diabetes. As I said in earlier slides, monogenic diabetes, it is 3-generation transmission with only one parent affected, whereas in type 1, family history is usually negative. Monogenic will have a C-peptide preserved, whereas in type 1 it is absent. Monogenic diabetes will have pancreatic autoantibodies absent, whereas it is present in type 1 diabetes. And monogenic diabetes responds to sulfonylureas, and type 1 diabetes needs lifelong insulin therapy. Gestational diabetes mellitus. Glucose tolerance developing during the second or third trimester of pregnancy is classified as a gestational diabetes mellitus. Insulin resistance is related to metabolic changes of pregnancy, during which the increased insulin demands may lead to impaired glucose tolerance or diabetes. Most women with the GDM revert to normal glucose tolerance postpartum, but have a substantial risk of 35 to 60% of developing diabetes in the next 10 to 20 years. Currently, the American Diabetic Association recommends that women with a history of GDM undergo lifelong screening for development of diabetes or pre-diabetes at least for every 3 years. So, thank you for the patient listening. The take-home message is, we all know that diabetes has become a national epidemic. So, it is essential to hereafter have a regular blood glucose checkup, diet, and good amount of physical activity to keep the disease in check, so that we can have a diabetes free world. Thank you.